Hi, everyone. Thank you again for joining our first webinar of 2024. And again, thank you for your patience as we get started. I am Miriam Khan. I lead communications for Gradient Health Systems. And I will just take you through a few housekeeping notes before we get started. And then I'll turn it over to our moderator, Dr. Papicho, who will get the session started. Next slide, please. Great, thank you. Just to quickly run through this short welcome, if you have any questions during the webinar, please use the Q&A feature to ask us. There's also a chat function. If you have any comments or issues during the webinar, please feel free to throw it in there. As you can see, the webinar will be recorded and you'll also receive a copy of the webinar following this session. If you don't, for some reason, to your email, it's on our website at gradienthealth.org under the training page, or also on our YouTube page at Gradient Health Systems. And as always, we would love to hear your feedback, your questions, your suggestions for any other webinars to come this year. We'll be adding more sessions as we go on through 2024. So please reach out to customers@gradienthealth.org with any feedback, suggestions, or comments. And now I will turn it over to Dr. Papicho, who will take us through introducing our panelists and kick off the session.
Thank you very much, Mariam, and welcome to all our participants all over the world. Thank you for being present today when discussing approach to spinal anesthesia, induced hypotension in Caesarean section. As we all know, Caesarean section is one of the delivery modes for a pregnant woman. And of late, delivery by Caesarean section has increased. And as we are talking today, we all know that every day there's a woman dying when giving birth. The WHO, together with all the health organization bodies, are coming up together to see how they can reduce maternal mortality. So we want, as we discussed today, we come up with some objectives, some way of working on how we can reduce mortality due to Caesarean section, and mainly goes by hypotension intraoperatively. One of the objectives today will be first to define hypotension. When do we talk about hypotension during spinal anesthesia? We will discuss the mechanism of action of spinal anesthesia. This hypotension comes when spinal is given. For you to be able to fight it, we should understand how it comes along and then how spinal works. Would like to discuss the physiopathology of hypotension. What does it do to different organs in the body? What is the consequences if you don't take good care or if you don't prevent the hypotension? Not taking good care of that can lead to maternal mortality. What are the principles of treatment for the hypotension? We'll have a very elaborative discussion with our panelists and our two presenters. So the first presenter will be Dr. Oceana, and the second will be Dr. Kelvin. These are great anesthesiologists from Tanzania who have been exposed into their practice, so they'll be here to present to us the topic of the day. Dr. Oceana, you are welcome.
Okay, thank you so much. As I was introduced, I'm Dr. Hosiana, anesthesiologist at Bugando Medical Center, Mwanza, Tanzania. And I'm glad to have this very important discussion with you on the spinal anesthesia-induced hypotension. So I'll take you through the first part. So we all know that spinal anesthesia is the method of choice. If there is no any contraindication, we choose it as a method of anesthesia during cesarean section. This is especially for elective procedures. And we usually prefer spinal anesthesia over general anesthesia because of the common risks which are associated with the spinal general anesthesia, such as we know these women have high risk of aspiration during intubation, and also pregnant mothers have high risk of difficult intubation due to airway edema. And we know that most of our anesthesia drugs crosses the placenta and can have a negative effect to the fetus. So we usually prefer spinal anesthesia over general anesthesia for these reasons. So how does it work? So the spinal block induced sympatholysis, that they block the sympathetic activity, which lead to vasodilatation. And this vasodilatation causes hypotension to the mothers. And hypotension during cesarean section, for the cesarean section which are performed under spinal anesthesia, has been a subject of medical research for a very long time. So I have one question for you, all of you. We know that when these mothers get hypotension, many systems are affected. So I want you to have answers in the chat box on the GIT effects these mothers get after having hypotension following spinal anesthesia. So you can write your answer on the chat box and we can have a discussion later on the GI effect, which these pregnant mothers got after spinal anesthesia when they got hypotension. So you can continue writing while we'll continue the discussion. So what's the definition of hypotension? So different studies have been having different definition on hypotension. So there were a review of 16 different studies which were done in a period of 10 years. And there were 15 different definitions. And all these studies use systolic blood pressure, which were measured in the arms in different body positions. And the most common definition of hypotension used in research studies were the decrease in, okay. So the most common definition was the decrease in blood pressure by 20% from the baseline blood pressure, which was measured before anesthesia. This is very important because some studies show that during anesthesia, there was increase in blood pressure. So the baseline was that blood pressure which was measured before anesthesia. So a decrease by 20%. And some of the studies used two criteria, which were a drop in systolic blood pressure to less than 100 millimeter of mercury or lower, plus or a drop in baseline blood pressure to 80%. So hypotension after spinal anesthesia has been found to occur in majority of elective cases when a robust strategy for prevention and management was not followed. And the incidence of extreme hypotension, which was defined as decrease in less than 75% of the baseline, has been reported to be higher than as 38%. So in these studies, the incidence of hypotension during spinal anesthesia varies with the range between 7 to 70%. This shows that it is a very common complication which can occur during spinal anesthesia. So what are the cardiovascular responses which occurs after hypotension? So as we say, when you do the spinal anesthesia, it results in sympathetic vasomotor blockage. And what happens when you block this sympathetic response? There will be a decrease in systemic vascular resistance, which leads to arterial dilatation, but with some venodilatation. So in healthy individuals, compensation is mediated via baroreceptors, resulting in increase in heart rate and stroke volume and vasoconstriction in unblocked segments. So in term pregnant, the baseline heart rate, stroke volume, and cardiac outputs are already increased to meet the metabolic demand of the present fetus in the stomach, impairing the ability of the cardiovascular system to compensate. So the GI response that I asked previously, so some of the participants say nausea and vomiting, some say ileus, some say there is increase in GI motility. I see many of the answers are nausea and vomiting. So let's see. So the GI response that occur after spinal induced hypotension, we know that with the hypotension, there will be reduced in splanchnic blood flow by approximately 20%. And also with the decrease in splanchnic, there will be release of hematogenic substances such as serotonin, which causes nausea and vomiting. But also there is vagal dominance. We know that the sympathetic is blocked, so the parasympathetic take over. So with the vagotone leads to contracted gut with active peristalsis. All this causes nausea and vomiting. Okay, next. So on the respiratory response, we know there is minimal alteration because we know that the mass of respiration diaphragm is innervated by the phrenic nerve, which is C3 and C5. But in high thoracic levels, there is a tidal volume is unchanged, but there's small decrease in vital capacity due to effects on the abdominal muscles. So apnea sequence are due to brainstem hypoperfusion rather than the phrenic blockage. So when these patients have apnea, it's mostly due to hypoperfusion to the brainstem. We know that in the brainstem there is a respiratory center. So when there is hypoperfusion, you get the apnea rather than the blockage of the phrenic nerves. So you can write on the chat box the risk factors for the spinal induced hypotensions. You can write as many as you know. What are the risk factors that predispose a woman to have spinal-induced hypotension. You can write on the chat box, then we are going to discuss them later on. So the pathophysiology of spinal anesthesia-induced hypotension. So there are several pathophysiological mechanisms, but the most significant one which has been studied is the rapid onset of sympatholysis. We know that pregnant mothers have increased the sensitivity of nerve fibers to local anesthesia. So this leads to rapid onset of sympatholysis. And it's difficult to predict the degree of spread. So it's difficult also to know the level, to predict at what level your drug can go. Because when you inject the drug, you cannot say like, I want this drug to end in T6, so it's difficult to predict the level. And sympatholysis can lead to a higher degree of peripheral vasodilatation and predominance of parasympathetic activity. So what happens with vasodilatation and predominance of parasympathetic? They'll be reducing in venous return. And when there's reduction in venous return, there's reduction in cardiac preload, resulting in bradycardia and nausea and vomiting. So with the reduction in preload, we said this leads to reduction in cardiac output, leading to systemic hypotension. And we know with these pregnant mothers, the hypotension will be aggravated by autocaval compression by the gravid uterus. And the higher sensitivity to local anesthesia combined with autocaval compression to pregnant uterus are the main reasons that cause the incidence of hypotension to be higher in pregnant women than others. So as we said, these women will have nausea and vomiting, which occur frequently during spinal anesthesia. And we say primarily it can be due to hypotension. So with acute hypotension, reduces blood supply to the brain, which induces transient brainstem ischemia. And with the ischemia in the brainstem, it activates the vomiting centers. And this has been shown in the study, which when they give oxygen, it shows that it prevents cerebral hypoxia, and thus reduces the incidence of nausea. So severe and prolonged maternal hypotension also has been shown to cause vertigo and decrease in level of consciousness. As we discussed previously, the splanchnic hypoperfusion, which decreased in less than, when decreased less than 20%, it causes release of serotonin, which aggravate the nausea and vomiting. Okay, so the hypotension does not affect the mother only, it also affects the fetus, but the studies which has been done to show the effects on fetal physiology in human are very little. But studies have shown that neonates born to mothers with spinal-induced hypotension were significantly more acidotic. And the duration of hypotension play an important role than its severity. As studies have shown that maternal hypotension lasting longer than 4 minutes have been linked to neurobehavioral changes in the fetus in the first 4 to 7 days of neonatal life. So the duration matters more than the severity of hypotension. So it is very important to prevent this spinal-induced hypotension. As we say that the consequences are both for the mother, as we saw that every system is affected, but also the fetus suffer. So with the fetus, as we say, hypotension was associated with fetal acidosis. And these also babies were born with low Apgar scores. And with the prolonged hypotension, the neurobehavioral changes were observed. Also, for the mother, hypotension have shown to cause nausea and vomiting due to reduction in brainstem perfusion, which causes ischemia in the vomiting center. So as much as possible, we should try to prevent hypotension rather than to wait for hypotension to occur and start treatment, as we have seen that both mother and the fetus are affected. So the risk factor. So the risk factors, some say autocaval compression, poor position and reduction in preload. Another risk factor, ephedrine was not given. Another risk factor from Prosper, say inadequate fluid preloading. Chitan say no preloading, supine hypotension, and macroscopic fetus. So thank you all of you. So these are some of the risk factors which were studied in different studies. So as one of the participants say, the fetal weight has been shown to be one of the risk factors. When the fetus weigh more than 2.5 kgs, the risk factor for having hypotension is high. Also, the level of the blockage, which we say it's difficult to predict the level, but the level when it becomes higher than T6, the risk has been shown to increase. The ASA, when the woman is ASA 3 or more, the risk also increases. So the risk of having hypotension increase when we have additional factor. When we have more than one factor, the risk increase 2 to 3 fold. So there was a score which was formed to predict the spinal hypotension. This score is called the PRAM score, which uses 3 parameters, which can help you predict the occurrence of spinal hypotension during cesarean sections. And these parameters were the pulse rate, age, and mean arterial pressure. So with the pulse rate more than 90 beats per minute preoperatively, and when the age is more than 25 years, and MAP is less than 90 before anesthesia. So when women have all the 3 parameters, the chances of having hypotension intraoperatively is more than 50%. And when is having 1 parameter, the chances of having hypotension intraoperatively become like 20%. So this score we can use to predict the occurrence of spinal hypotension during spinal anesthesia. So I welcome the next presenter to take us through the prevention and management of spinal anesthesia-induced hypotension.
Thank you very much, Dr. Osana, for the great presentation. It was very clear, and our participants, we enjoyed their participation to this first part of the presentation. And we wish them to continue same active participation during the second part of presentation, which will be taken up by Dr. Kelvin. As we said, Dr. Kelvin is a great anesthesiologist practicing also in Tanzania. He's going to share with us the management and other part of the presentation, also using his experience due to his great exposure. Welcome, Dr. Kelvin.
Thank you. As I was introduced, I'm Dr. Kevin, based in Tanzania, working at one of the hospitals called Bugando Medical Center. So I'll be taking you through management of spinal-induced hypotension. So what do you do to prevent hypotension? So as we see on the presentation, there are different ways that we can do to prevent hypotension. One way is to give fluids to your patient. Then you can use vasopressors and prevent out-of-cover compression. So if you do all of this, they could help to prevent spinal-induced hypotension in your setting. Next. So as you can see from the slide, one of the ways of preventing out-of-cover compression is to do manual uterine displacement, as this helps to relieve the outer and inferior vena cava. As you can see on the diagram, you can see on the left diagram A, you can see the child is resting on both the outer and vena cava, which reduces the venous return to the heart and reduces the cardiac output. But after left uterine displacement has been done, or if the patient has slide left lateral, hello. Sorry, we're having some issues with the, so I will use Dr. Oceana's, yeah, so as I've said, when you look at the pictures A and B on the right side, you can see that when you are having a mother who is lying on supine, you can see that the child is compressing both the outer and the vena cava. And on the left side, you can see after left uterine displacement, there is a relief of the vessels, which has helped to return the blood back to the heart, which helps to improve the cardiac output and decrease the incidence of hypotension, and also decrease the use of vasopressors. So another way you can do is to tilt your table 15 degrees. I think most of us are doing this in the theaters, which is also of benefit in reducing the spinal-induced hypotension. Next slide. Okay, so another way that we can reduce spinal-induced hypotension, we can use leg compression. So we can use either bandage or boots or anything that you have, like antithrombotic stockings, which will help also to increase the preload of the heart, and will help to reduce the problem with hypotension. We can also elevate the legs 30 degrees, which is also another way that we can improve our preload and cardiac output. Next. So here is what most of us have been talking for a long time, if we should do preload, or if we should do colloiding, or if we should use crystalloids or colloids. So I think many people, they have different ways of practicing. So the recommendation, we can use preload of 15 to 20 mils per kg over 20 to 10 minutes before induction of anesthesia. This will help to maintain the intravascular volume. You can also do colloid preload, but the problem with colloids, as we know, you can have allergic reactions You can impair your renal system, coagulopathy, and it's also costful to use colloids. You can also use crystalloid colloiding. So as you are administering your spinal anesthesia, you can also give your fluids at the same time. So this is beneficial, has been shown to be beneficial because of the pharmacokinetics of crystalloids. As you know, the distribution of water or the crystalloids when they're in the body, some remains in the vessels and others go to the interstitial fluids. So when you do colloid, it has been shown to be better than preloading. Colloiding, this has shown no difference when you're doing colloiding or preloading because of the pharmacokinetics. So if you're having a patient who is dehydrated, it's better to do preloading instead of waiting until you're doing spinal anesthesia. That's when you're doing colloiding. So it's better to preload your patient. So it depends with the patient that you have. Instead of, if your patient is well hydrated, then you can do colloiding. But if is dehydrated, it's better to give fluids resuscitation of your patient to improve the outcome and prevent the hypotension. Next. So as we know, we have different vasopressor therapy that we are using in our centers. So the vasopressor that we use commonly, we use ephedrine, adrenaline. So ephedrine works on different receptors, and it's an indirect working vasopressor and has weak effects as a vasopressor. It's slow on action and duration is prolonged. But the problem is you get tachyphylaxis. The more you use the dose of ephedrine, with time, it doesn't really work because of tachyphylaxis. And when you use adrenaline, so ephedrine we usually give boluses of 3 to 6 milligram. And we also use adrenaline, which acts on both beta and alpha receptors. It acts directly, its action is immediate, duration is short. So sometimes we use adrenaline in case ephedrine doesn't work. So in our settings, we can double dilute our adrenaline. So we take 1 milligram of adrenaline, dilute in 10 cc of normosaline, and then take again 1 cc from there and dilute again to get 0.01 concentration. And we can give boluses of 1 cc each time you get hypotension. Next slide. So on the picture, we can see the importance of increasing the vascular resistance, either by adding fluids. So if you add fluids, so you can see on picture A, there's stressed volume, the fluid is less. But when you add fluids, it helps also to increase the volume in your blood vessels, and it helps to increase the blood pressure of your patient. And when you see diagram C, when you use vasopressors, you press your vessels, which will also help to increase your blood pressure. Next. So how do we prevent hypotension? So we can use prophylactic measures, which are like left lateral displacement of the uterus, by tilting the table or using a wedge, aiming until at least 15 degrees of pelvic tilt, or we can use IV fluids. As we have talked before about preloading and colloiding, there are different studies which are talking differently about this, and using crystalloids or colloids. But most of us, we have crystalloids, and most of us are used to preloading. But the studies have shown colloiding to be of much better to improve hypotension. We can reduce the dose of local anesthetics. We can use 7.5 to 10 milligrams of bupivacaine. But the problem with reducing the dose, we can have insufficient anesthesia duration or incomplete block. It's more effective when you're combining spinal and epidural anesthesia. So effects of wrapping lower limbs with compression stockings or bandages, it has shown some effect on preventing hypotension, as well as using Trendelenburg bag position up to 20 degrees. But we should be careful with Trendelenburg bag position, because if you have given your spinal anesthesia and then you do Trendelenburg bag, you have to be careful about the high spinal and total spinal. So this should be done before the application of the spinal anesthetic as a prophylactic measure. Next. So we have another question which you can answer in our chat box. So would you recommend ondansetron to prevent spinal block induced hypotension? So we'll see your answers on your chat box. Next. Okay, so management strategies that we can use to manage hypotension. Okay, so we can either do reactive treatment at the same time that you're having hypotension, or prophylactic. So this is more of timing, or we can do boluses or infusion of your drugs. We can also do infusion combined with colloid. So we can give crystalloid colloid with phenylephrine. This drug we mostly don't have, but we can combine if in your center, if you have phenylephrine, you can combine, which helps to eliminate hypotension. And current practices recommend use of vasopressors and fluid corralding. So some centers have norepinephrine, which is still evaluated as an alternative to phenylephrine. It might be more beneficial, but it's still, it helps to maintain uteroplacental oxygen delivery. So it's still on research as an alternative for phenylephrine. Next. So how do we manage hypotension due to spinal anesthesia? Administration of vasoactive medications like we have discussed, ephedrine, adrenaline, is essential to help to manage this spinal anesthesia-induced hypotension. Dopamine was used before, followed by ephedrine, but recently phenylephrine, norepinephrine have been used as an alternative. Ephedrine administration after a drop in blood pressure. So normally we usually give 3 to 6 milligrams after a drop in blood pressure. And similar effects have been observed when using ephedrine and phenylephrine in preventing and treatment hypotension, in treatment of hypotension. So phenylephrine, though, was associated with lower incidence of fetal acidosis and maternal nausea and vomiting. Next. So for optimal management of blood pressure, we can do colloiding with 1 liter to 2 liters of crystalloids, or we can give infusion of phenylephrine if you have, of 25 to 50 mics per minute immediately after spinal anesthesia. And it should be titrated depending on the blood pressure and pulse of the patient. The goal is to maintain arterial pressure of greater than 90% of baseline measured before spinal anesthesia. The problem with phenylephrine, it compresses your blood vessels, which can cause reflex bradycardia. So that's why norepinephrine has been studied recently as an alternative. So if you're having phenylephrine, you can try to use doses which could not cause this bradycardia. Next. So on ondansetron, let's see some answers on ondansetron. Okay. So most people I see they're saying they haven't used ondansetron as one of the methods of preventing hypotension, and some says they haven't used it. So let's see what we have for you about ondansetron. So it has been studied as one of the drugs that can be used to prevent hypotension. So there's this reflex after someone is having hypotension. There's a reflex called Bezod-Jarisch reflex from chemoreceptors. So it causes the patient to have bradycardia, and it worsens the hypotension. So as ondansetron activity, it blocks serotonin receptors. So serotonin receptors are the ways which this reflex, cardioinhibitory reflex, is working. So if you block that, it could help to relieve the hypertension. So the problem is it's not really indicated for routine. So it's still on research. Next. So it's still very early to recommend routine administration of ondansetron. It's still being studied as an alternative which could help to reduce spinal anesthesia-induced hypotension. Next. So recommendations that we recommend: hypotension following spinal anesthesia. It can cause maternal and fetal adverse effects. It's a frequent problem, and therefore vasopressors should be used routinely and preferably prophylactically. Alpha agonists, like we've talked, which is phenylephrine, are most appropriate agents to treat and prevent hypotension following spinal anesthesia. Though we also would recommend a small dose of beta agonists, like noradrenaline, metaraminol. So phenylephrine is currently in use or recommended because of the data, is supporting data that is supporting the use of it. Left lateral uterine displacement and IV colloid preloading or crystal colloiding could be of additional use in addition to vasopressors. Our aim should be to maintain systolic arterial pressure greater than 90% of baseline that you measured before the onset of spinal anesthesia, and avoid decrease of less than 80% of baseline. Next. Maternal heart rate can be used as a surrogate for cardiac output. So you should avoid tachycardia and bradycardia. When using alpha agonist as vasopressor, first-line vasopressors, that means phenylephrine, small doses of ephedrine are suitable to manage systolic arterial pressure of less than 90% baseline. So for bradycardia, we can use atropine or glycopyrrolate if we have. We can also use adrenaline if possible. So the use of smart pump or double vasopressor infusions can lead to greater cardiovascular stability than that achieved with physician-controlled infusion. Women with preeclampsia, they develop less hypotension after spinal anesthesia than healthy women. So abrupt decrease in blood pressure undesirable because of the potential for decreased uteroplacental blood flow. A prophylactic vasopressor infusion may not be required, but if used, should be started at lower rate than for healthy women. Women with cardiac disease should be assessed on an individual basis. Some conditions are best managed with phenylephrine. So just an arterial constrictor without heart effects. But we can also, in some patients, they also respond best to ephedrine. Next. So our take-home message, anesthesia providers must always keep in mind that the clinical context in which they practice obstetric anesthesia. They must select the appropriate strategies, individualize patients to combat spinal-induced hypotension, and ensuring maternal and fetal comfort and safety. The incidence of spinal block-induced hypotension is high in preloading. Left lateral position and co-infusion with ephedrine were found to protect the participants from spinal-induced severe hypotension. Thank you. So these are our references. All right.
Great, thank you so much. I will turn it over. I know we're having some connectivity issues, but Dr. Papicho, I think you're on. I'll turn it over to you.
Thank you very much,
for
Dr.
Q&A.
Kelvin, for the nice presentation.
Recording it.
I was just checking the question and answer.
Thank you very much, presenters, and I think we have lost one of our colleagues. I think next slide. So I will take this opportunity to welcome you all for any question, clarification, if there's something need to be clarified. Please, you can raise your hand, and then you can unmute your mic, and you can ask a question, or you can even send a question in the chat box. So please, you are welcome. As we are waiting for questions and answers, that I would like to use this opportunity to thank you, Dr. Siana and Dr. Kev, for such a wonderful presentation, elaborative, and actually, I think you have covered most of the important area regarding this topic. As you all know, C-section are actually increasing in number, and actually, the mode we are using, most of us, is spinal anesthesia. So taking care of the complication could save a lot of pregnant women. I think we have obstetrician, unless Dr. Chetan, can you please share your experience? I think we have one of the senior colleague in the participant. Chetan, if you can hear me, please unmute, and maybe you can share your experience as you're waiting for questions from participants.
I have a question basically on the urine output, because recently I've been having some issues with urine output, especially when I use some vasopressors, adrenaline and ephedrine, either as a bolus of ephedrine or the effusion of adrenaline. Most actually, even after giving efficient fluids, I still don't get the urine. So I just want to know the effects of these vasopressors, especially on the kidneys and the urine output. Thank you.
Thank you very much for the question. Maybe I should. Ndaba, are you available for that? Or okay. Luciana, can you respond on that? Okay, so I think I should try as we are waiting. So so the question is, one of our colleagues is not getting urine output. Of course, yeah. Even after
Luciana is having some network issues.
Okay, that's fine. So I think we should looking at vasopressors and the kidney. I think that by the time you are giving vasopressor, you should know most likely you have severe hypotension. Yeah, this is the way I'm looking at it. So by the time you are giving vasopressor, most likely you have severe hypotension, which means one of the areas which are affected is the renal perfusion, which means you're already affecting the urine output. So I think we needed to clarify one thing. So how long do you see this? Is this only interpretive 1 hour, or does it continue even post-op, maybe 24 hours later, or to see if you're getting injuries? Or I think we need to get some more clarification. But also we should know, as I think Kevin responded. In the past, we even used the dopamine, which we know it has some kind of renal protective, but the rest of them actually they don't have that. They don't have any action in the renal. So I think we should stick on preventing hypotension, because that's the easiest way of preserving renal function. Because hypotension, severe shock, severe hypotension and shock. This also will end up causing with the pulmonal injuries. So you giving inotrop is you are trying to improve the perfusion, but I think we needed to stick on making sure we prolong and prevent the hypotension. That's how I see it. I see it like it's more on you giving the inotrop. Most likely you are still behind fluid, or you are still resuscitating, which we understand that the kidney may not give you enough urine. So unless if it stays for a longer time, I think that's another story. Maybe you are getting injuries. But if the interoperative one gets a severe injury, you get severe hypotension, and then you give a fluid, and then you give inotrop, you should not expect to get enough urine at the same time, because you are still resuscitating. I think I hope I answered your question.
Yeah, yes, you did. Actually, it is always like it is intraoperatively, because like 12 hours post-surgery, you still find when there is urine in the bag, but intraoperatively, I'm always worried because I don't see urine most likely.
So I think you should stick on preventing the hypotension, because the urine will never produce the kidney will never produce urine if there's nothing coming to the urine, to the kidney. That's a challenge we have. So you have to keep the volume. You have to keep the good volume in the vessel. Of course, the use of inotrop. with the fluid to make sure the BP is stabilized. That's the only way you will keep the physiological with the body running physiological. And actually, I'm happy. I'm glad to see that you are monitoring urinary output even intraoperative. Not everyone does it. So congratulations for that.
Thank you.
So we have another question. In the most of our hospitals, immunosuppressor are not available. What do we have? Flight. There's no alternative to vasopressor. Maybe, but I'm sure you have at least adrenaline. Yeah. In the event that you have only adrenaline, you can do the double dilution. I think Dr. Kevin discussed about it. So you can do the double dilution and then you can use it. And actually, it is. I think that's the only alternative you should have if you don't have the fancy one. If you don't have the other ones. So how do we approach a woman with antihypertensive drug before giving spinal agent? I think I'll leave this to my colleague, otherwise. Andaba, Kev. Someone on antihypertensive coming for spine, for surgery and spinal anesthesia.
So I think if they're on antihypertensives, they usually should continue with their medications before administering spinal anesthesia. So we normally don't stop the antihypertensives.
Yes, I quite agree with you. Yes, so I think by then you have done your pre-visit and you know which drug are they using, and then you have discussed with them, and then because when they come in, you just you take the baseline blood pressure and map as like any other person, and then you continue with your technique. The most important thing you have to keep the blood pressure to the. You should avoid the hypotension as much as possible. So I will look for. If there's another question, please raise your hand. Otherwise, I think there's no much questions. I will. So no question. No raise the hands. So I think. Okay. Shaban Saleh, can you please unmute and you can ask.
Okay, I have one question concerning about the most health centers have problems of bed treated. Most of the beds have the problems. Thank you.
So sorry, I think I missed the guy. Can you please repeat? I think it was most of the bed they are not treatable.
Yes.
I say that the most of the health centers have the problems of bed. So in case of head treated and left lateral, so how can you elaborate for those cases?
So Ndaba, can you please respond?
Yeah, can you hear me?
Yes, we can. We're going to continue.
Okay. Yeah, so sorry. We are really having a terrible internet strength here. But I hope you can hear me clearly. Yeah, so I think with respect to the question about the challenge with beds, I think that's a common challenge in our, in our setting, especially our remote facilities, where we have beds that are very difficult to tilt, such that you can't even do, lateral tilt. You can't do, you can't elevate the head side of the bed to prevent, high or total spinal. It's a real challenge. But again, we have to find a solution to it. I think generally what is basic and simple to do, and that I've found quite useful is to have some kind of pillows each time you're doing a spinal anesthesia, because sometimes even when you have a bed that can tilt, a bed that you can easily maneuver, sometimes they fail. And so you have a challenge in terms of making sure that you position the patient properly. So pillows do actually help a lot. If you can have one or two with you, so that immediately after you've given your spinal, or indeed you want to position your patient properly, you can easily shove it in at the back of the patient so that you have the head side slightly elevated to prevent hypotension. So pillows, things like, I think you can use basic things like folding maybe the blankets, and this should be done actually before you even give your spinal anesthetic. So this should be, you have your pillows near you, or even folding the blankets that the patient had come with near you, so that that can easily be used to wedge the patient up, or even indeed do a lateral tilt before the baby is delivered. I think that I found that quite useful. And indeed, the challenges of beds, my friend, you are not alone. I think this is a challenge everywhere, the challenge that we share. We have these odd beds that are sometimes very difficult to maneuver. And I think I just want to also quickly make a comment on the part of preparation. I think preparation is a very crucial thing, regardless of the type of anesthesia you're giving. Because recently I've been seeing colleagues, because you've been doing it so many times, we tend to take it for granted that it's only a spinal, so I'll just give a spinal and that's it. Remember, when things go wrong, that's the only time that people will start questioning and looking for errors and things like that. So preparation, I think, is very, 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 very important in actually preventing or managing hypotension indeed. One of them is, I think, like we've mentioned, the pillows, little things like pillows, making sure that you have some oxygen running with you, and preparing all the drugs, preparing the workspace. I think that in itself really helps to get away with hypotension, or even indeed preventing hypotension, in addition to the knowledge that we have. So I think for me, the key, the secret is preparation, which also include patient assessment, to understand or identify who is at risk of having a spinal hypotension, or whom you think you can manage with just giving preload fluids, or whom you think you can do a co-load, and those that you think you can actually administer vasopressors from the onset, even before they develop hypotension. And I think that's very important. Then the other thing is on the monitoring aspect. Just after giving a spinal anesthetic, I think that's a very crucial time when you really have to monitor and make sure this patient doesn't develop hypotension. And then this hypotension happens very quickly. You can have stable vitals in 1 minute. In the next few seconds, the BP is already 60/40 or 50/20. It can happen so fast. So you need to make sure that your IV access is good. Sometimes I always encourage people to have double IV access. It doesn't hurt. Even if you don't use the other one, it's still okay. Double IV access, so that you don't panic when the blood pressure starts dropping. And sometimes you are in a situation where you're alone, the surgeon is grabbed, the theater nurse is grabbed on the other side, the porter or the assistants are all over the place, and then you have 40/0, in terms of blood pressure. So I think we always need to pause and make sure that we prepare our patients well, and indeed prepare for potential hypotension and how we are going to manage it. I think if you can hear me clearly, those are the comments, Sweetbet, I wanted to make. Thank you very much.
Thank you very, very much, Ndaba. I'm trying to see if there's another question. Yes, you can use bolus of ephedrine as a prevention. Okay, that's, I think, this man was clarifying. Okay, so looks like we have tackled most of the questions which were asked. Thank you, Brian. Well elaborated and nice presentation. Okay, so I think so. If you have a question, you can always email it to us, and in the email we presented in the presentation, the training email. But also you can visit our website. So to reach out for our recorded webinars and other materials. So I will welcome Magdalena. So the email is customers@guardian.org. So welcome Magdalena for the last part of our webinar.
Thank you very much for joining the webinar, and thank you so much for the lively discussion from the participants. Thank you so much, Dr. Hosiana and Dr. Kevin. We just want to let you know that as Gradient, we value our users for our machines. We have the ICV, the CCV, the UAM, the old version and the new version that has double vaporizers. And we also have one that is coming up, the KO2, and we also have a Prima, which is another UAM machine. So I'd like to thank you all for joining and staying up to the end. And what I would like to mention is that we'll also start a kind of webinars based on the use of our machine so that we get to know which hospitals are having challenges where and when. So look out for that. So we'll be doing still the clinical, and still for those of us who have our machines, we'll also be reaching out to so that we can bridge those gaps that you're having in the use of the different types of the machines, the ventilators, the UAMs, the UMVs, and come with your questions and come armed so that you are able to be taken through everything. Thank you so much, and wishing you all the best, and have a lovely evening. Thank you all.
See you on the next one. Thank you.
Bye.